All right, I'm going to share that again. Cool. So yeah, thank you guys very much for joining. I appreciate it. I'm Daniel Novak. I know pretty much everybody on here today, and I'm sure folks in the future. I'll probably have met them as well who are watching these recordings. This is a little bit about my background. If I don't know you that well, I've been around for a while. I'm as I always say, hashtag not that kind of doctor. I'm a social psychologist of education. And so my question though, and my recent years of interest have been in medical education. How do we prepare doctors for the future? And that led me to this position here at UCR School of Medicine, and I love it. And I'm having a time of my life working with medical students and helping them get connected to research opportunities and to learn about research. And I do a lot of teaching around that here. And that's what kind of brought us to acquiring TriNetX for the campus. That took me about 12 solid months of contracting work and stuff like that to get it, but it's been great. However, I do not have any funding or formal support from TriNetX. They are just a vendor for us. I don't have any kind of relationship with them beyond our contract. I don't have any shares or funding to disclose, nothing like that. Some of my salary time for this bootcamp were paid for from funds from an NIH U54 grant held by UCR and City of Hope, but that's not really related to TriNetX in particular, and the grant itself in no way specifies the use of TriNetX as part of our work. I'm not getting paid anything extra out of that, so I just want to make sure everybody knows that I really like this tool just because I like it, because it solves a huge problem our community has, but I don't have anything in particular behind that. So the Bootcamp weekly overview, just to let you know, I tried to break this out into chunks that would be manageable, and I noticed from having tried to work with students and faculty, it can be overwhelming. The platform is very easy to use, but it's like one of those things, an afternoon to learn, but a lifetime to really master. So that is something that I think, what's going on here? That is something that breaking this out is going to make it a little easier to understand and to figure out the platform and how it's going to fit with your research interests. So this week, we're going to start with navigating TriNetX and developing a project. We're going to define and explore cohorts. In the next week, there's a really rich platform part of doing that, as well as talking about how we define cohorts and what that means. We're going to compare cohorts and do propensity score matching in week 3, which is a really great way to make sure that you're doing a scientifically valid study. And in week 4, we're going to look at outcome analyses and do a little bit of peer review together. And then in week 5, we're going to move on to how to create this into a paper, or into a poster rather, or a paper. We're going to start with the assumption that at the conclusion of this, you're going to want to have created a poster for your platform. For your study based on the data from the platform. And having worked with a lot of students during the PIP program, we were able to, I think, come up with a pretty good process for doing that. The bootcamp objectives are to, at the end of this, you will know how to navigate the TriNetX interface, identify worthwhile projects, compare outcomes between patient cohorts, and use propensity score matching to reduce confounders and increase your validity. So I think that's going to be a lot of fun, but we're actually going to learn a lot more, so much more than that as we go. I just thought those were kind of my top 4 things that we walk away with. Today's session and objectives, big picture overview of TriNetX. We're going to talk about navigating it, identifying key features of the interface. I talked with some first years when they first encountered it early in the year, and they were like having some difficulty just finding where to get your study started. So we're going to really start from the beginning. Some of the stuff you'll also find in the navigating TriNetX component, you'll also find on the platform itself. They have a really, really well-developed help guide. I think just the way I'm going to do it is based on having worked with a lot of students. Theirs is more like, tailored in some ways to the clinical trial developers. That is the bulk of their group. But when using this for research projects, either as students or as faculty or as residents, my navigation emphasis is going to be a little different than what's on the help documentation. So that can be useful. And then we're going to talk in the second part about how to actually develop a project. I talk with students about this all the time, like 3 times today alone. How do I get started with a project? And I think we'll find some, I found some creative ways to help a little bit with that. Each week is going to have like a little bit of a balance between technical training and conceptual guides. So each session is going to cover a piece of that technical training and also provide you with some conceptual guides on how to think about the data, the platform, and your project. Please don't skip either part. I mean, yes, it's important to learn what buttons to click. That's super important. But you also need to understand the conceptual guide. Otherwise, you're going to wind up running head-on into problems, or you're going to not understand how to connect some things together. So I think understanding both the conceptual components and the technical components will really help with that. As I noted, and I'm going to put these in the chat as well. Again, thank you for all the kind words in the chat. But we do have a number of materials, including books, articles, some kind of class bibliography that I'm putting together as we go, as well as some tools and things that will be valuable in the long run. Let me just show you the page. So if you go to navigate to the page that we link to in our email, you'll see here we have our recordings on here, and you're going to see each one as we go through. I'm going to post them to this site. And then here's also the resources themselves. So here I found some excellent books: Handbook of Epidemiology, Clinical Epidemiology, Stats for Clinicians. These are all free books that are available from Springer. You can just download them from the UC library for free onto your device as PDFs, so you don't have to like have them in a weird reader or anything like that. But a lot of the chapters in here, I selected each one because it had a chapter or two that focused on really valuable stuff. One of them tells you about like, what is a Kaplan-Meier curve, which we're going to look at a little bit in both really technical, but also really general language as well. And the clinical epidemiology and the textbook of clinical epidemiology do a good job of connecting some of the larger epidemiology and public health terms to clinical questions and interests. So these books are free. They're for you. Please click on them and download them from their website. I've also got some tools for finding TriNetX studies that are going to serve as some of the recipes for your project later. We're going to talk about that concept in a bit. What is a recipe? TriNetX publication database, Google Scholar. I already have this one plugged in to start searching for TriNetX studies when we begin. And Research Rabbit as well, which is a platform that can help you find interrelated studies and make sure help you kind of explore things a little more graphically and visually. I'm also developing this little, as I find good studies, I kind of add them in, and I don't know why that one doesn't work, but in either case, you can see what some of the good examples of articles that I've been finding that meet the criteria that we're going to talk about today. I also have some help videos in here. I link directly to the help guides in TriNetX. They're really wonderful people over there. If you need something, you can always email them. But they also have some really great videos that will complement these. I also developed and will share with anyone who wants it a ChatGPT bot that has been trained on the TriNetX documentation and all the other stuff. So you can ask it questions like, help me set up a study comparing these two outcomes. What would my cohorts look like? And it'll help you do that process and give you the codes and that kind of stuff. So you do need, I think, a ChatGPT Pro account. I've been trying to make it so you don't need one, but it's unclear how to do that exactly. But feel free to give it a try. It's been pretty helpful. And I have an undergraduate student in data science who's going to continue training that over the next couple of months. Last two items that I'm trying to make your life easier with is a project tracker. I know a lot of folks out there are going to want to work on projects over the summer, so you can use this platform. This little thing here by scroll down a little bit. You can hit this little plus sign here and add your project directly. Sorry, this is for the faculty mentors. You can add your project in directly through this project tracker link right here. So if you add your project into this, it'll go into this spreadsheet and it'll show up on the website. So if other people want to work on a project but they don't have an idea yet, they could jump in and join in with you. We have 2 students already posted those. We also have some faculty who have expressed interest in mentoring students. So I've listed their name. I'm going to try and get their faculty websites included in here as well. But we have some folks from City of Hope who are planning on joining in, some of our folks from across the different disciplines. and they would be happy to spend an hour or two sitting with you to work over your project and discuss it. So that is hopefully going to be very helpful to everybody. Last, before we move on to the actual content of today, I wanted to let everybody know that we also have some templates here as well that I put together to make life easier. I'll call them out as we go. We have some templates for tables that will help you for your poster. We have a cohort diagram that I'll tell you about in a little bit, as well as a science poster template itself for those who've never made one. I want to make this as easy as possible for you. So yeah, recordings, they're going to be on the website. Important links for today. If you don't yet have your TriNetX account, please do go to the Bootcamp website and request yours. I did want to make everybody aware of an opportunity that's coming up. Dr. Pilecki and I, as part of our work on the NIH U54 grant with City of Hope, Dr. Pilecki is going to be leading the development of a symposium starting in that's going to be in mid-September. So we're going to have more information about that soon. We're just getting the dates locked down. But if you complete this boot camp and want to present a cancer-related project, any kind, it can be cancer treatment, cancer disparities, outcomes. I talked to some folks who are interested in mental health outcomes related to that. That would probably be a good fit. You can submit this to our September symposium. Be great for your CV, great opportunity to network with folks, and also a really good way to develop your project, keep yourself motivated for the development of your project, so you'll have something to present in September. You can also then present your poster at Dean's Research Day at the end of the year as well, once you've had some feedback and had an opportunity to develop it. So if you got any questions on any of those, please go ahead and put it in the chat. I'm also happy to answer any questions verbally that we need to. But let's talk about the meat of today, because we're already underway. Let's talk about TriNetX and health informatics. I know a lot of times it's hard to figure out what the pun they were going for with TriNetX, but it's a clinical trial network, right? X, network X. But anyway, you can say it like genetics, right? TriNetX is how I say it. And apparently that's their goal as well, is that joke. So for those of you who aren't familiar, haven't heard my spiel, TriNetX started out as a clinical trial matching platform some years ago to help make it easier to connect different clinical sites with clinical trial managers. So let's say you're Merck and you've got a new drug, you want to try it out on folks. Well, how do you find the right exact subset of people with the exact right conditions to test your drug on? Well, TriNetX was designed to solve that problem, but along the way, it was connected into all of these major health systems, electronic health records. So right now it's hooked up to 64 health systems, including our own, and it ingests the data. I believe for most sites, it's monthly. So the data is kept fresh and brought in all the time. And it comes directly from the electronic health records, but it's been de-identified for everybody. So it's safe to use for research purposes without additional human subjects approvals. And it's really wonderful. So those, there are globally, I think 120 something health systems, including in the US, it's UCI, UCSD, USC, Johns Hopkins, Virginia Tech, University of Iowa, the Ohio State University, health systems in Texas, and it goes on and on and on like that. So there are all these groups, their demographics, diagnostic information about their patients, procedures, drugs, labs, genomics, visits. All these are available for the hundreds of millions of patients the 100 million patients that are on there. And it really makes it easy to query and find these data so you can run really cool stuff. As I said, there's no HIPAA information anywhere in the platform, and it's restricted in ways that keep patients safe. We're going to talk about a couple of those as we go. And the average age of the patient record is something like 7 years. So that means you have some people who only have a couple of years, but you also have people who maybe have 15, 20 years of records in there that go all the way back to the dawn of the electronic health record system at these sites. So the data are cleaned as they're brought in, so it's very high quality. And that's as it has to be in order to use it for the kinds of drug discovery and clinical trial matching stuff that the corporations are using it for. That, by the way, is who's paying for it. The drug companies pay to run their trials through TriNetX, and we get the benefit of using the platform for research purposes. As I said, data is refreshed weekly or monthly, depending on the organization. You can think about it like this. We've got our global data set with 145 million patients. We have our US and data and research network with 113 million patients in it. We have our own UC collaborative network with UCI, UCSD, and UCR. That's 2.6 million people. And then we have UCR Health, which requires UCR Health approval. We've agreed with them that it's probably a good idea to ask permission before we give people access to that network, just because it's a very, very small network, and we want to make sure that people have really good use cases for it. But that shouldn't be too onerous and is doable if you really are a UCR Health, UCR student or health employee. We can negotiate access for that. As I said, geography on this, we're going to talk about some of the limitations of the data set, but geography is obscured beyond UCR. So once you start looking at the the UC collaborative network, the collective, you can't tell whether the data is coming from UCI or UCSD or UCR. You can't tell whether the data is coming from 92507, or you can't tell what zip code the data are coming from. You can't tell what state they're coming from. And this is all to protect both the healthcare entities themselves and the patients. So it does put a little damper on some of the work we'd like to do, and we'll talk about both what those limitations are and what works around that. In a bigger picture, conceptually, before we look at the actual platform itself, TriNetX thinks as a cohort-based platform. So it's thinking about groups of people that share common characteristics, whether those be demographic, medical, linguistic, whatever you think your study might be looking at. Studies are retrospective, of course, but what's interesting about it, as I've read more and more about the methodologies associated with using these kinds of large data sets, one thing that's really interesting is the cohort comparisons can create natural experiments. That is, even though they're not prospective, we can actually see what actually happens to people in these studies and create groups of them as if they were being categorized into experimental conditions. Let me see, I've got a question in the chat. When you're doing national level studies, can you divide by state? No, you cannot. You can look at it by census region, but you cannot conduct an analysis by census region or state, anything below that national level. So that's just a factor to your platform or into your idea, and we'll talk about that in a little bit. Another thing that the platform can do that's really valuable, and I think really makes it a great tool for us to both learn about and do quality research, is propensity score matching, which is a way of adjusting for confounding variables like age and pre-existing conditions. And we're going to talk a little bit about that later, but it's basically a way to help reduce some of the random variability or some of the potential bias that might be introduced in doing these kinds of real-world studies. We're going to look at it and actually use it, but I just want to talk about it. Has an easy-to-use cohort builder. It has both search functions, and you can also use some of the different medical coding components. We're going to talk about those individually in a moment. It has a powerful in-system data analysis tool. So that's something that I think has been really, really important about this platform. Is one of the bottlenecks we have is we only have one Dr. Guth, right? We only have a couple of biostatisticians that we have available to help us with projects. And this platform really takes some of that burden off, because we can do a lot of really good quality analyses with these before we get to the level of starting to ask for help outside of the platform. And this is, I think, where a lot of really publishable and good projects start. Let's see, I have a question in there. Is there any estimate as to how many patient charts are covered within the data set? If you mean patient records, which would be, in this case, the same as patient charts, about 113,600,000 as of today, and it grows every day. We have another question. Can you filter data by years? Yes, you can actually do that in both the incidence and prevalence function, or you can set absolute. If you want to look at a change in policy or a change in standard of care, you can filter by years when those standards or changes were instituted. So yeah, both of those things are possible. We're going to get into this a little more in like week 3-ish of this boot camp. But basically, there's a whole range of tools. The analyze cohort and competing risks functions are going to be in some ways the most valuable to us, especially the compare outcomes functions here are going to be really useful. And that's going to be kind of my assumed use case for a lot of you out there. TriNetX does allow you to download data off of this, but for right now, number one, the IRB wants to see what you're going to download before they allow you, before anyone signs off on doing that. So it actually adds an extra layer of burden to download the data set and try to run the data by hand. And also, after talking to a student who actually is extremely statistically literate and very proficient in R, it's very difficult to manage these data sets. They can be in the gigabytes. They have an enormous amount of data about patients. Every single thing that gets entered into that record comes out with the data set. So I'm encouraging everybody to stay focused on using the platform to its maximum capabilities before we start taking data off of the platform. It is possible, though. We can do it once we have exhausted the other options. I don't like to start with the bad news, but it is good to just mention, because a lot of people start from places of like that are kind of limited of use cases for TriNetX. So the first kind of limited use case would be geography, as we talked about. You can't look at anything at the state or zip code level. That's going to be really challenging. Questions related to insurance status, those are sometimes kept in similar systems. We can only access it for about 11 million people through the TriNetX linked system. And right now, we're really not able to answer a lot of good questions on insurance status. I know that comes up a lot, but there are lots of good questions that don't involve insurance. It does impact a lot of outcomes. Length of stay. How long were patients in the hospital for? I think I literally just got this question from somebody in the chat. So yes, we cannot see how long the person was in the hospital for. There are proxies we can use for it, like how long between visits. TriNetX actually does collect service days, so how many days people were in the hospital, but we actually have to take the data off the platform to view it. We can't analyze it on platform. So unless it's super critical and the only way you can answer a really important medical question, length of stay is not a great choice. Sensitive data types, neonatal questions. We're going to look at a little bit at sensitive and restricted codes in a second. But we did find that some of the neonatal questions are restricted in a way that make it very difficult to do. So if you're a neonatologist, that can be challenging. Accidents, incidents, or violence can also be a challenge. We're going to talk about exactly what falls under those categories in a bit. But if you want to look at car accidents, that's quite challenging. One of the hardest ones is questions related to ambiguous or qualitative outcomes or information not otherwise collected by the EHR, like patient-reported pain outcomes. Unless that's something that's standardized and collected in an EHR, probably won't show up. Comparative costs of treatment, well, that's not going to show up in an EHR. That's usually in another system. So that would be challenging to do. Great use cases, risk likelihood, like how likely is somebody to have one kind of outcome versus another. Long-term outcomes for patients where it would be hard to track them or watch their outcomes. Otherwise, experimental conditions that might be otherwise unethical or impossible to replicate in the real world. We have a question here. Are behavioral health data hard to obtain? Depending on the behavioral health, not necessarily. A lot of stuff is coded and input in there, so we can look at those examples and talk about some examples. But yeah, so that's the big picture stuff. I don't want to belabor that too much, but I want to give you all a big overview of this. Basically, why TriNetX? Well, for medical students, it's really what I've learned and been really glad to see is that as you make use of this software platform, it goes a lot beyond that. It goes a lot beyond getting stuff for your CV or for getting your GME credits met for those of our residents and stuff. It actually, I think, allows you to build your own clinical medical knowledge, because in order to understand what you're even seeing in some of these platforms, you need to have a deep knowledge of what's happening biomedically and clinically. And I think that's something I've seen is students really grow and learn and become independent, what they call from the AMA, they have a framework, like really master adaptive learners who are asking questions and really able to build their expertise. And I think that's also what program directors and residents are really looking for when they're asking you about your research or looking at your CV for research, other than just a number. They want to know, are you self-directed? Are you self-motivated? Can you learn about stuff that you don't know? Or do I have to spoon feed you everything? And I think TriNetX helps you learn a lot about medicine on your own, and then learn more and get engaged in clinical expertise. And hopefully some of the mentors that we have on our call are going to be really crucial in helping to expand your knowledge as well. I'm going to talk real quick about the rapid development process, because research takes a long time, and medical students and residents and everybody else, we're all pressed for time. You don't have 5 years of a PhD to just sit around and contemplate the nature of reality and social relationships and whatever. You got projects you want to set up. You got questions you want to answer. So I kind of developed this little process on screen that I really think helps walk people through it. First is obviously, and you're going to hear me say this 1,000 times because I tell students this all the time, you're probably all sick of this, reviewing the literature is the first step. Knowing what's already known and where there are questions and gaps is the first step in research all the time. You're going to define your questions and build your cohorts. That's kind of what we're going to cover today. You're going to look at and generate you're going to compare your cohorts, do propensity score matching, generate your initial outcomes, rebuild your cohorts if needed, get feedback and self-critique, and then write up your results. I have an even faster version of this to show you all a little bit later as we get into the next, into the conceptual part of today. If you don't fall asleep or fall off the call by then, I think it's an even easier way to approach getting started, because that's really in some ways the hardest part. Another thing to be aware of, key features in TriNetX. I kind of broke this out into two components. My metaphor is super clunky, so bear with me as I refine this over time. But basically, we're going to split the features part of TriNetX into two parts. We're going to talk about the foundation of your study to this week. And then next week, we're going to talk about what I call, or sorry, in starting week 3, we're going to talk about, I call it the house, right? So your foundation are the core components that make your analysis, the house, possible. It's super clunky. I get it. But it does help think a little bit about your foundation supports the validity of your findings and helps you develop your study, your inclusion and exclusion criteria and your justification for those things, time, order, and frequency of events, and cohort exploration for confounders. That's really the foundation of your study. And here's your little house. A house is where that supports the outcomes. It's the analysis type, the cause, effect, order, and your propensity score matching, and those really help develop it. So I'm going to take you through all of these, and when you do all of these things, it really helps to build that study nicely. So I love my draw. This is really the best artwork. This is your refrigerator, mom putting this up on the refrigerator quality work right here. It's a dumb analogy, but like I said, it's going to help ensure the validity of your claims by making the most of the TriNetX platform's features. Relating cause, effect, and time, temporality is super crucial. Avoiding common evidentiary mistakes that result in bad data, and giving you a roadmap for your future projects. All right, so as we get here, I just want to tell you a little bit about this worked example we're going to do. I'm going to expand this out over time. I tried to develop this and set it up so that I can show you examples of how to do things well and how to do things poorly as we go. And it's really hard to, I've worked with a lot of students where they're not quite sure what they're interested in yet and not quite sure what they want to work on. And it's really hard to learn about the software until you have a really compelling use case. And that really just turbocharges everything. So I'm going to tell you a little bit about an example that I found that we're going to look at. And it's also a good way to get at some of the tacit knowledge, the things that I've learned that hopefully I can share with you and discuss ways of thinking about things. So I'll be coming back to this at the beginning or throughout the program to kind of give you some examples. But this worked example starts with some internet clownery. That is some jokers on social media spreading junk science. So I want to take an opportunity to train our sites on some junk. Social media is full of absolutely questionable advice, and that really inspired me. I like this. I used to like this guy's videos a lot. He has some really good information on prenatal nutrition and women's health and all sorts of really important stuff. And He's German and he has a very stern, all of his videos look exactly like this. But one day he got up on his platform with like 2 million followers, and he claimed that Alzheimer's is a physician created disease. And his claims were that it's physician created and it didn't exist 40 years ago. It is Alzheimer's didn't exist, also not under another name 40 years ago, and exponentially increased with systematic abuse of statins and fear-mongering cholesterol. And his claim is that statins unbalance cholesterol metabolism and cause reductions in myelin sheathing and problems in myelin sheathing. And that's why there are higher rates of Alzheimer's these days, which is complete bunk. Like, we don't even really have to dig into this too hard, but I do want to look at it a little bit. And this is where I think the power of a really great software platform that can help us do data could be valuable. Alzheimer's, no, just number one, has been around for over 100 years. It's been around since 1906. And the first statin was commercially produced in 1987. So 81 years of people, and Alzheimer's cases steadily increasing as diagnostics got better. And also as other factors were identified as being core to this issue. It just doesn't even pass the smell test. But I will say that there has been, this is I think from a week or two ago, some new questions about whether maybe we're overprescribing statins to the general population, right? Fewer people may need it, but also even worse, the people who may need it aren't getting them, right? So it may not just be doing its job as thing, which is a totally reasonable discussion to be had with lots of really interesting questions to be answered. And ultimately, people like me should be making those decisions. Physicians like you all out there should be making those decisions. But Alzheimer's, the issue or the question of Alzheimer's with cholesterol, with statins, it's even more complicated than that, right? There's a lot of issues to consider. And this is just what I came across in my own readings about this. There's dosage over time. There's length of treatment. There are comorbidities that are highly complicated. There's dietary considerations. Beef consumption is correlated with Alzheimer's increases across the world. Everywhere where beef consumption increases, so does AD. Maybe a correlation, maybe causation, we don't know. Or no one has definitively shown that. A poor understanding of Alzheimer's causes, the diabetes type 3 hypothesis. We got prions, we got inflammation, we got beta tau protein functions. We got Dr. Carson and glial cells, an expert in that. I'd love to hear, her thoughts on that as well. There are genetic phenomena, like differences between ApoE3 and E4. There are ethics issues, and even if statins do cause maybe a slightly higher long-term possibility of Alzheimer's, is it ethical not to use them to lower triglycerides if, in fact, that actually promotes heart health in the short to midterm? Smarter people than I will have to debate that. But there have been some recent meta-analyses that have looked at statins, and the results in this one, the results confirm the absence of a neurocognitive risk associated with statin treatments and suggest a potential favorable role of statins. RCTs with an ad hoc design are needed to explore the potential neuroprotective effect. And you can see here that dementia risks were reduced by 20% and Alzheimer risks were reduced by 32% on people with statins. But also, there's yet another on top of that. That one was from 2022, and there's another one from 2020 that looked at another set of meta-analysis of RCTs and found that the studies indicated that treatment with statins slow the rise of neurodegeneration and actually lead to better outcomes. So we got that. That's great, right? I mean, that's pretty compelling evidence to say that, at least statins are not that bad. Maybe, we don't know. But what about real world data? Well, we've got TriNetX, right? So no one's done a TriNetX study on Alzheimer's yet in this particular way. There are other studies looking at COVID's impact on Alzheimer's, but nobody's looked at statins and Alzheimer's yet. So it's perfect as an analytical tool because it's hard to get longitudinal data on Alzheimer's patients because people drop out, they die, all sorts of negative things occur along the way, accidents. It's hard to randomly assign people to a statin, no statin group because they may need those statins for other immediate health-related issues. Cohort matching can be challenging due to multiple comorbidities and complexities, which we can control for in TriNetX. And it allows us to ask some specific questions. So just to show you a window into how I kind of have seen these things and thought these would be valuable. To what degree do my question might be phrased as, to what degree do statins impact people's odds of developing Alzheimer's? Well, RH sub 0 is that there's no associated change with likelihood at all, right? Perhaps we might say with H sub 1 that there is use is associated with a lower likelihood of developing Alzheimer's disease. But then we could also ask some additional questions about time on treatment and how that impacts likelihood, and dosage impacts and how that impacts likelihood, because those studies are very hard to conduct in the wild. Today we're going to just do the cohort, and that's going to be a good place to stop because that alone is a lot of stuff. But I just want to take you through a little bit of some of the key components and things that I've noticed people have trouble with in TriNetX. So when you get your account, first we're going to just look at this basic process of setting up a study. So you can see over here, I've taken a screenshot of it. I'm going to do a mix of screenshots and live website today in this just because sometimes, websites don't act the way you want them to. But when you log into your site, I noticed some students were telling me they couldn't find any interesting data in there, but they were just going to like this browse network type area over here, and that really doesn't have any meaningful data in it. What you really want to see is this create new study function. And when you click that, it's going to allow you to create a new study that's going to house all of your queries. You can have as many studies as you want. You don't have to stop at one. You can develop them as frequently as you need to keep your work organized. And when you create a new study, I'm sorry, I'm just my Duo is finishing over here. So while that loads, just got to wait for the thing to load in. But you're going to see this button over here. So that's going to be your first stop as you're developing your project. You're going to see you can create the study. The items listed here over on the on the screen are the items, are kind of like the required responses, like what you need to fill out in order to kind of get the study launched. I'll just show you really quick. You're going to need to include a study name. I'm going to, just a placeholder. You're going to also need to check these boxes here that say other scientific research. These boxes over here are just for clinical trial research. You do not need to use them. So you're doing other scientific research. You're also going to need to select a primary therapeutic area. For my purposes, I always use public health. It doesn't really make a difference for this because this really helps and focuses mostly on who's going to get the data, or who's going to get the clinical trial stuff. So your primary therapeutic area can be anything. And then that's about it. Once you have that information in there, you can create your project and get started. Conversely, you can also click the share study button. So once you create your project, you can hit the share button and add other people on it, like at Dr. Morrison. Oh, Dr. Morrison Magazine have an account right now. So I'm going to add one of our colleagues out from the field. You can feel free to ignore this, but I'm just going to add you to this project to show you. And then what's great is anybody else you're working with, they're immediately going to see the project show up in their studies account. So that's really useful as well. And I think they do a great job generally in TriNetX in enabling the sharing and kind of co-working functions on the platform. It's really great. All that information is kind of set up in here, so you can take a look at it. On to part two, starting a study. There's really two sets of features that I want to call attention to. Your available networks and your query builder. So we're going to start with that. Everybody gets started with their loadout. Mine's going to look a little different, but your available networks are visible right over here. And I think I have a screenshot of it coming up on the next slide. But basically, it allows you to pick what area you're going to look at. You can look at the global network, right? So if you click on that, the global network has about 148 million patient records in it across 123 health organizations in 20 countries or something like 15 countries, something along those lines. France, the UK, Israel, Russia, Taiwan. Those are just the ones. Japan. Those are the ones I know about. Brazil. So you can look at those if you're interested in something biomedical, but not necessarily clinical. That would be impacted by the unusual nature of the American healthcare system. You could also select the US network, which is where I do most of my work. And you can see over here that it's got about 113.6 million patient records in it as of today, as I was telling you earlier. So we're going to stay with our patient network for the moment. But just to let you know, those are going to be mainly your options for this project for the use of TriNetX. If you need UCR help, we can provision you for it, but I have to go up to some higher ups to ask them. Now the query builder. So I'm going to talk about 7 things that are kind of really important about this function. It's incredibly powerful, but these are some things that I think are really particularly important and useful. The first is the term search box. To give you a sense of what that looks like on the platform, here we have over here, it's this guy right here. So this can help you search for your term. So if you're looking for asthma, you just type it in and it'll search for the words directly. Conversely, if you wanted to know, if you already knew what your CPT code was or something like that for asthma, you could simply type in J45 and look, their asthma is right there, right? Fantastic. So yeah, making sure you use that, use the full range of search functions like that can really help you find what you're looking for in there. I also want to highlight 2 columns, the must-have and cannot-have functions. And I'm going to tell you where those are right here. You can see over here on this side, this is the cannot-have function. So it's got its own search box. So you could say, I want to actually see studies where no one has asthma, right? Or I want to see my study where everybody has asthma. So must-have, cannot-have. That winds up being really useful as a tool. And you can drag criteria back and forth, just like I showed you. And next week, we'll get into really granular ways of arranging these things to get exactly the subset of people into your cohort that you're looking for. Let me show you these 2 things. They're going to be really useful and valuable for you as you go. Term filters and hierarchies. So the filters look like a little coffee filter or like a little, I don't know, funnel here. And your hierarchy map is over there and looks like a series of little dots, right, in a hierarchy. So what's really valuable about this is, for example, if we were conducting a study and we were looking at the A1C values of folks, I'm just going to save that and I'll show you. You can click the little term filter here, and it'll give you some additional options, like being able to specify the A1C value of the people you're including in the study. So you can say, now my cohort is only going to include people who also have A1C or an A1C value in their most recent, you can also choose some additional values in here. Like you can say you want their most recent lab, or there may be other situations where you want to see if their blood sugar has ever been 13, because you might want to know about what their life was like in the past. But in this case, we're going to look at our most recent lab result. So that's really valuable. The other component, as I was saying with something like asthma, is the hierarchy function. And you can use that. It appears for pretty much everything in your study, whether it'd be a drug or a lab or a condition. But you can click on the hierarchy, and what it does is jump you straight to the place in the code hierarchy where that term lives. So let's say you picked or searched something, you found your moderate. I'm going to add this in your moderate persistent asthma, but you wanted to go back and actually also select mild persistent and severe persistent asthma. You can then use the term hierarchy function to jump back into the hierarchy and find what you're looking for a little faster. So that'll help you find things more faster and more quickly and systematically. So yeah, really useful, really fun to use, I think, as well, because they're highly visual and interactive. Another thing I want to talk about is Boolean logic. A horribly boring subject in math, but what is interesting and useful about it is in these studies, you can see when I mouse over these little ands or ors, it'll flip back and forth. So in this case, what we're doing is everybody who's ever had a statin and has an A1C over between 7 to 13 and has asthma, right? Now, we could, if we do that, it's going to create a very narrow subset of people who meet those characteristics. It's going to be much smaller than the sum of all of these numbers of people. Like we have 7 million people just on Lipitor, right? So when we look at people who are on Lipitor and have an A1C over this and have asthma, we might actually wind up with a very narrow pool of people. So just letting you know, but it can be important. In situations you might not want to have any of these. Like in this case, my study is ruined because I might be getting a soup of people who have statins and have A1C between 7 to 13 and or have asthma. So they could have any of they could be any of these things. They could be all of these things. We don't know. So using your Boolean operators really helps you connect these things together. And next week, we're going to see an even cooler, more granular and complex way to really make sure you're getting exactly the right people that you're looking for. We've got a question here. Does the platform have access to both structured and unstructured data? Only to structured data. So this platform only looks at, there's no patient notes or qualitative data in here. It's only going to be structured data of some sort or another. Or if to the degree that there is sometimes unstructured data that has been turned into structured data, that may also be the case. So cool. Now let's, as I was saying with the count patients button, you'll find that as you add people to the cohort, your number of patients in these groups won't change until you hit the count patients button, because that blue button is the one that locks in your characteristics and queries their database to look for what's available on there. So now we can see that our group of people who are on a statin and have a high A1C and asthma is about 168,000 people over 57 to over 57 healthcare organizations. So that should be enough to get our study rolling with that. So you'll see that when you hit this blue button, a little card shows up over here. Like you can see, my original study was with these statin folks with the 12 million people, but this next one shows up like this. These little cards show up in your view, keeping track of the information in there. So the count patients button winds up being really valuable. These are the query cards I just described. As I said, they also track the number of patients and networks that are in your query, and you can rename them. I highly recommend, you know, there are lots of different ways. I tend to do stuff like statin by high A1C by asthma. So you can find a way that works for you for naming them, but I strongly recommend does that. That is really the way to go. You can also put in notes to yourself like, try to create a more specific danger group. I don't know. Whatever you might want to put in here. And these notes will help you kind of work along as you go, and they'll help you remember what you were working on more clearly. I got a question in the chat that asks, does the AND function only compare the last statin and the A1C, or should we make a different group for the Boolean comparison? We're actually going to look at that a lot next week. You can look at whether it was the most recent A1C and the most recent statin. You can control them individually like that. And next week, when I show you how to create term groups, we can really narrowly create different groups. I have to break that up because it's just too much for one session. So if you can hold on a little bit or come see me, I can tell you a little bit more about how to create tighter relationships between the last statin and the most recent A1C and those kinds of things that might be above the value. Just a quick conceptual note on cohorts and outcome. Your cohorts should never include the outcome that you're going to use when you conduct your analysis later. The reason for that is you're going to wind up creating a circular situation. So let's imagine that I'm looking at my goal here is to look at statins and then see what their outcome is on Alzheimer's. Well, if I include Alzheimer's in here, I'm going to have 100% of my cohort having Alzheimer's, which makes no sense, right? Like, why would we? Of course, we know it's a circular relationship. So you got to think a lot about what goes into your cohort that is before your analysis and what goes into your cohort later, further down into your analysis. So when you're comparing cohorts or looking within one cohort, your outcome measure that you're looking at, let's imagine in this case it wasn't Alzheimer's, maybe it's COPD or something like that. We could look and see what percentage of these people wound up having COPD. That would be fine. We could add COPD to this cohort and add Alzheimer's to the outcomes, or vice versa, and that would be okay. But you can't put you can't create a, you don't want to create a circular definition for yourself. That's, I know that may be a little confusing, but I think as you try to create your own study, you may see a little bit about how that fits. I got a question here. If someone qualifies under two categories in the Boolean comparison, patient is taking two statins, are they disqualified? Do they show up twice? No, they'll show up once because they'll meet either of those characteristics, right? So if you say this person can take this statin or this statin, they'll show up once, because if they're on both statins for some reason, I don't know why, I'm not that kind of doctor, but if they were, you could see them, you'd only see them once because they would meet the characteristic one time. All right, so starting a study, where do we get started on some of these things? I want to take you through a first year came up with this, and it actually has been super helpful for me. He says, I was like, oh, we got, demographics, diagnoses, procedures, medications, and labs. I was like, oh, I wonder if there's like an acronym. I know how med students and doctors love acronyms or mnemonics. And so he was like, doctors don't pay money late. And I was like, all right, works for me. Helps me a lot. Maybe that'll remind you. Doctors don't pay money late is a reminder, a mnemonic for remembering to check all of your variables and all of your components that you want to include in your study. I'm going to go through these real quick today just to give you a sense of what's in each one. Demographics includes age, sex, race, ethnicity, marital status, and vital status. And there's two places to see all of these data. The first place, I'll show you the live version of this over here. The first place on the platform is over here where it says, it's kind of like an innocuous space for how important it is, but it's this little thing that says age, and age, any sex, right? When you click on this little button next to it, it'll show you all of the distribution of the ages and genders of the people in your population that you've defined in your cohort so far. And then you can do stuff like say, you know what, for my statin study, it makes no sense to look at like 20-year-olds on statins because something else is going on with them. I'm really interested in people between the ages of 50 and, I mean, I also don't know, I'm not an expert in that, 50 and 70. So this is going to be the real narrow zone of my folks, because we should see, or maybe 80, we should see onset of dementia or Alzheimer's disease around this time by then. And by then, they'll also probably have been on a statin for 10 years. If they've been on them for a while, at some point in here, they'll have been on it for 5 or 10 years. That'll give them enough time, ideally, to make sense. You can also select male or female, depending on what you're looking for in here. And be sure, please, to save your criteria before leaving the screen. There's so many times where I forget to hit this blue button down at the bottom, and I don't save my criteria. But you'll see here now, once we've redefined it, it'll tell you basically on our network, there are about 39 million people who fit this parameter for the study. I'm actually going to remove it because it's going to mess up a bunch of other stuff later. But yeah, so that is where you're going to see your age and sex. And as I said, please remember to hit the save criteria button. Let's see, we've got a question. At what time point are subjects included in the cohort defined? If a patient has ever received a statin, will it be included in the cohort, even if the patient is currently not taking it? Yes, but you can actually define when the person enters the cohort relative to taking the statin, and whether they've had it prescribed more recently or been given it more recently. in there. So there's actually a way to determine how long a person has been on a drug for. We're actually going to look at that much more next week when we look at the create new group. And there's also a way to do that in your analysis as well. Thank you for the great questions. And we get, there's a lot more to say about that one. Demographics in the query builder, really quickly, just to show you. The other zone where you're going to find your demographics is in this bucket here. So just to show you real quick, when you click on your study, you can also click on this little hierarchy button, and it'll show you all of the available things. If you don't feel like searching, or you know where you're going to be looking for things, you can click on that button. It'll take you through it. Here's the demographics components. You can see here you have ethnicity, whether you're looking for Hispanic or Latino folks, your language, marital status, race, and vital status if the person is deceased. You'll only see deceased people in this system if they passed away in their hospital system where their records were held. If they died at home or in an accident or something else, you probably aren't going to be able to get their measure. But there's about 8.8 million people here whose mortality you could use as an assessment. And as I said, the race component mainly focuses on the U.S. Census data. It's as good or bad as the U.S. Ability, the U.S.'s ability to actually maintain these records and ask people about their perceived race and identity, or self-perception of race and identity. But it's pretty good, and it'll help out with a lot of health disparities research that we would want to do. So demographics available here. We're going to look at ICD-10 codes next. Based on ICD-10 codes, which were merged with legacies, they can search by disease, condition, or organism, by name, or by code. If you don't know a code, as I said, you can Google it or check my ChatGPT bot for help with that. Specific codes, by the way, though, are sometimes collapsed into one code. So I know, especially in dermatology, there's a lot of stuff that students are interested in, but they're kind of collapsed under like other skin conditions because they don't occur frequently enough to really warrant their own code in the international data set. So that's just a thing to be aware of. Another thing to be aware of is that there are some sensitive and restricted ICD-10 codes. Now, you can still interact with them, you can still see them, but there are certain kinds of analyses that we can't do in this platform using some of these codes. So certain things in the early perinatal newborn phase within the first, I believe it's 30 days of life, can be restricted. You can still see them. I have a student who's doing a project related to cryotherapy for a new neonatal issue. But we have to do some of our analyses manually because it's just important, as the TriNetX folks put it, it's important to protect our babies. So those are restricted. Vehicle morbidity and mortality, and V is not always accessible. And accidental non-transport drowning, so suicide by drowning. My favorite of them all, though, is the least it's not a bummer, at least, is X52, which is for prolonged stay in a weightless environment. There are only like 520 cases for that code, and those are all going to be astronauts. So I thought that was really funny as a thing that they had to figure out to restrict. You can access that right here in the diagnoses section, and you can search for it. You can look for, here's tuberculosis. If you need to get everybody who's ever had tuberculosis into a cohort, you can click that button and add that section using your ICD-10 codes. So really useful. To go along with the ICD-10 codes are the procedure codes. We're going to skip oncology for today, just because these data come directly from the National Cancer Registry. So they're a little specific to, and not everybody may be working with them. And they're not the only source of cancer data in the system. They're just really handy and interesting. So we can always talk about that another time. But your CPT codes can be very precise. The AMA maintains these, and they have them for like every conceivable billing code in the world, so it seems. They can be very precise, and that leads to a lot of them. And you can use the term hierarchy function to see related codes very nicely. For example, the amputation of the left toe, the metatarsal phalangeal joint, I don't even know what, but there are all these really specific codes. I would suggest I'd consult in Google or a medical coding guide to make sure you have the right procedure code before you do stuff. Just as one example, I was using a procedure code that when we were doing a project on peripheral arterial disease, I thought was about going in through the femoral artery and doing an atherectomy in a person's leg, but it actually turns out it was for going from the femoral artery into a heart blood vessel. And I didn't know that, didn't have the expertise to know that until somebody spotted that for us. So just be aware that these codes are very, very specific. So whether you go up the artery or up the vein or up or down the vein really can make a difference. Next up, medications. That's the next tab over. This is your doctors don't pay money late. Your money is your medications. And you can see here, it's got them all listed in these categories in really useful ways. So you can find them. I'm going to add something real quick. Oh, actually, since we already have our statins in here, when you click on them and click on the filter, it'll show you both the route, if it's oral or intravenous or whatever, and it'll show you what drugs are included in the brand name here. So here's Lipitor, right? And here's generic. It'll also show you the strength of the drug as well. So if you want to look at people on 10 or 20 milligrams, and that also is helpful in showing you the distribution of who's getting, you know, how many people. There's still a lot of people on like 80 milligrams, but it gives you a sense of what's going on out there in prescription land. So yeah, that term filter and the hierarchy filter can be very valuable in that as well. I showed you labs a minute ago. Lab values can be included in the system. Like I said, these ones that show, they say TriNetX curated like this over here, that can be super useful because TriNetX has taken multiple lab codes and kind of concatenated them together into one nice, easy to analyze chunk like that. And so we're almost done with technical training. And I know I'm a little over time on this one. I don't think next week is going to go as long, but I do have a little bit more to share. And so if you got to take off for the day, please send me some questions or feel free to email me or set up a time to meet. But I'm going to keep going, and you can always watch the recording later, or if you're bored and this is fun, hang out. In any case, next week in technical training, we're going to look at the advanced cohort design and explore cohort function. And that's going to talk a lot about what's going on in these different groups, and it'll make it a lot easier for you to understand what's happening. But let's talk about how to develop a project. I do want to set up some warnings for folks about roads to nowhere, because I hear them a lot, and I'm like, oh yeah, nothing's going to happen with this project. So after I should take people through the software, they go, oh, cool, thanks for the demo. I'm just going to go get in there and start playing with it. I actually don't think that that's necessarily a great idea unless you have something specific you're already interested in doing. And even then, I think a little bit of prior preparation and planning is really going to make it a much more effective time for you. You might say, I'll come up with a good idea as I use it. Well, that could happen, and that does happen. Your questions can change as you use the platform. But I think really great projects don't start with the software. Right? Great projects start in the library. This is the library where I did my dissertation work at University of Washington. You don't physically have to go to a library. I mean, most of the time I didn't, but I really enjoyed working in this room. And I do know it gave me an appreciation for the function of libraries in our work. But let me tell you a little bit about why I'm really harping a little bit on going back and doing a good literature review. The reason is in scientific research, I think we find a lot that scientific contexts, like, research contexts, whether it's, like UCR, maybe we're a little more rustic, right? We maybe have a little, our kitchen is functional. We do a lot with it, and we serve our community. But, our kitchen, has very different instruments than what you might find at like a City of Hope or something like that, right? Where they've got like, I don't know, they have like lasers, and they can, fire radiation and use magnetic fields to control them and all sorts of crazy stuff. So, maybe their kitchen looks a little bit more like this. Both are great kitchens. They can feed your family and do a great job of keeping everybody rolling. But the kind of work, the way your study gets done in these two different contexts can be very different. So if you're doing a randomized controlled trial in one context, it's going to be very different as an experience as another context. But TriNetX, my example, that's more like the Instant Pot of research. I don't know if any of you own an Instant Pot. A lot of people do. I think we all bought them for a while, and we still use ours. We just used it yesterday. But the thing about the Instant Pot is no matter where you put it, whether it's in a high-end kitchen or a more rustic kitchen, it always works the same way. It's the same for everybody. Yours is the same as mine. 3 minutes on high is the same for you as it is for me. It takes an annoyingly long time to come up to steam just for you, just for me. And you can do amazing things with it, though. It's incredibly versatile and does a lot of stuff. But even a great machine like that isn't useful without a recipe. So that's why I encourage folks to really get in there and find a good TriNetX recipe. And I'm going to tell you what I mean by that in a minute. But basically, like, if you don't have a recipe, how do you know whether, like, if you just kind of wing it, how do you know whether, like, this little, if you see this thing here, like this dish, whether the green leafy things on the top of the dish there, is that cilantro, is that parsley, is it oregano? Well, the recipe is going to tell you. In fact, this one tells you that it's cilantro. If you don't consult the recipe, you have to figure it all out on your own and guess, and you maybe will make a mistake. I'm all for YOLO cooking. I love that too. But for these kinds of things, you'll save yourself a lot of headache if you start with a recipe. So, like I said, existing TriNetX studies are your recipe. That's what's out there for you to use. The method section usually, asterisks, not always, lay out exactly how the study is structured, their cohorts, and what ICD-10 CPT codes and demographics were used. They also identify any group of codes that were excluded from the analysis and when that occurred, and indicates whether and how the propensity score matching was used, which is super useful. 3 quick places to find them. I strongly recommend TriNetX's publication listings. They're kind of moderately, they're curated, but they're moderately organized for you. I also strongly recommend going to Google Scholar and putting in TriNetX followed by your interest. And you can see here are some of the ones, associations of COVID-19 with new onset Alzheimer's disease. These are in very good journals. And you can see all of the different, there's a lot of, the software really started catching on during COVID. So there's a lot more COVID studies in there than I think we're interested in now necessarily, even though COVID's not done with us. So it's something to consider. Look through, basically search TriNetX dermatology, TriNetX melanoma, right? And look for what studies have already been done. That's a really good way to find them. I'm finding and trying to put in ones in interest areas that I know for folks in our curated SAP list. But if you can't find anything that already exists in terms of the codes that have been put out there or in TriNetX, if you need an idea, consider checking out meta-analyses and systematic reviews and scoping reviews, because the research summaries will tell you what they already know and have pretty well identified and what's not known. So here's a study on statins that I found. I think I showed this one earlier. We could not control AD-related factors because there's no detailed data such as cholesterol, carrying ApoE4, gene and gender, and there was no vascular diseases in the included AD patients. So we could not analyze how these factors affect the efficacy of statins in the treatment of Alzheimer's disease. So guess what? That's exactly what our study could look at, right? That's a really great idea right in there for something we could use TriNetX to look at least for several of those. ApoE4 is a little difficult to find, but there were no vascular diseases. We could look at all the different vascular diseases that people on statins then experienced, and we could control for that. We could remove that. We could study differences between cohorts that have those outcomes. So all sorts of cool stuff. So I showed you my rapid process earlier. This is what I think is the even more rapid process to help get you through a project in about 5 weeks. I think first start with your area of interest. Identify a study in a similar area. Doesn't actually have to be identical, just good enough that, like, my analogy here might be, if you want a cherry pie, but you like the crust from a Dutch apple pie, you could take those 2 recipes and kind of put them together, right? You could make the filling from the cherry pie and put the Dutch apple pie crust on top of it. it's getting on towards dinner and I'm hungry, so you can get a sense of where my head is at. But the idea here being that you can mix these things and remix them together to make it work for you, and also to save you the work of having to figure out what these key features like the ICD-10 codes and CPT codes, the timeframes, the cohort structures, what they've already done will help you get to your study more quickly. Reconstruct your study in TriNetX, refocus the structure on your topic or cohort, examine your outcomes, and check with an expert. So I think if for students or for faculty or residents, if you follow a process like this, you'll get somewhere really quickly this summer. Now, that's not to say to identically copy everybody's papers, but it is to say that you can use those papers as a starting place for your project. And I think that's actually really good science, right, to do that. Benefits to this approach: making sure you attend the following features in your study. We can do our best to achieve the following outcomes. Your study will be more likely to add valuable population health and clinical practices by filling a key gap. Your study will be less likely to produce a junk study that adds additional noise and uncertainty to an already crowded scientific field. And your study will be more likely to satisfy reviewers as to the comprehensiveness, accuracy, and methodological understanding of the project. And for me, these are the core values that I have in bringing TriNetX to our community, and I hope we can bring those together. I just want to punch through for a last little bit. Hopefully, it won't even take to the top of the hour. But here's a worked example. I found this study. It's not necessarily like the best study or the best journal, but it does have 5 or 6 features that I'd really like to see in our school's TriNetX publications and studies. Those key features, I kind of list them here. I'll just go through them real quick. First is a clear layout of inclusion and exclusion criteria for cohorts. So as you're looking for a study that you want to use as your recipe, this kind of thing is really helpful. And this article did a really nice job of saying these were our inclusion criteria. Cerebrovascular complications of stroke, arrhythmia, inflammatory heart disease, ischemic heart disease, all these things all the way down the list. And this makes it easy for you to redevelop this as well. Next up, they did a really nice job of a cohort construction diagram. So this gives a really clear understanding of how they divided out the people in their study from pieces from the beginning to the end. So they started with the US Collaborative Network, and then they looked at people who had more than 2 visits. They looked at people who are older than 20 years old. They excluded everybody with a COVID vaccination. Then they looked at people with COVID-2 tests. Positive people were in one cohort. Really makes this very easy to follow the logic of their study. So I made you a template like this so that you can build your own as you're designing those studies. And it'll really, I think, make it more compelling for your reviewers of your papers. So number 3, they are very clear about the temporal relationships in there. So the people from the cohort were longitudinally followed after 30 days after the index time to 12 months to estimate the risk of incident cardiovascular disease. So we'll talk about index events when we get into our analysis in a week or so. But this really helps make it clear when these events were occurring in relationship to one another. Use of propensity score matching when appropriate. They have a really clear rationale for why they use propensity score matching to help reduce random variance as a result of or confounding factors in their different parts of the study. We're going to talk about propensity score matching and how to do it and do it well. I hope well later on, but it's something you should be on the lookout for and see how they used it. I can help you apply it to your study as well. They had clear identification of potential confounders and means of mitigation in cohort construction. That is, they didn't just say like, yeah, there's some confounders. Oh, well, they thought about how to mitigate that, and they presented that as part of their methods. Number 6, clear. Yes, I'll share the Google template out there as well. It's actually on the resources page right here at the very bottom. You'll see the template. You can make a copy of it. You can make a copy of it to your Google Drive from mine. But here's your table one. This is really valuable. Pretty much every article uses this as table one, but it includes things like age at index, the gender, the race, socioeconomic status when possible, comorbidities and labs that all kind of work together to help people understand your study and what you did. I also created a template on that same page for table one. It shows people before matching and after matching. I'm assuming propensity score matching, you don't have to. And then we'll help you kind of collect all your data into one place, and ideally should be expandable. Also, you're going to need some kind of clear representation of outcomes. This one is a forest plot. I actually took this from a different study, but they're super easy to make, especially if you're doing a bunch of different outcomes, like what were the odds that people, or the risks that people had HPV or anemia or preterm birth or any of these different things. You can set it up in Excel very easily. And I included a video in this PowerPoint that will do that as well. Your results table, I included a version of this as well on there for you to use. Here's a results table that I recommend you use for posters and things like that. They really make life easier. You can represent things both as propensity score matched or non-propensity score matched in there, and it helps to show the cohort. I'll show you where these data would come from in your outcomes later when you're comparing your cohorts, and that'll be like week 3, I think. Yeah, so that's it. Those are some of the things I think are really valuable and useful to do in your study. And if you do them, I think number one, it'll help make your study look really impressive because you'll have really thought it through. And number two, it'll make it really stand out when it comes across an editor's desk or for a poster presentation. Okay, I'm going to open up for questions in just a sec, but next time we're going to talk about defining and exploring cohorts at a deeper level, and we're going to do a lot more work on really making sure that before you start your analysis, you dig in and you get exactly the people you want in your study before you start studying them. Okay, so thank you. I know we went 20 minutes over, and I appreciate your time on that. Please go ahead and ask if you got any questions. You can unmute yourself and talk. I'm going to just stop the recording here.